Dear Chair, dear audience, let me introduce you my PhD topic, which is dental management of children with special needs. Unfortunately, 60 to 80% of children with neurodevelopmental disorders have high anxiety and bad cooperation, resulting in general anesthesia for a regular dental treatment. As general anesthesia can result in complications and can prolong treatment, there is a strong need for some effective non-pharmacological interventions to decrease the necessity of general anesthesia. In our systematic review and meta-analysis, we showed that audiovisual techniques can improve both anxiety and cooperation levels by 11%. Therefore, dentists should consider implementing these techniques as part of routine dental care, and randomized clinical studies with stronger outcomes, such as the necessity of general anesthesia, should be done to elevate the effectiveness of these interventions, and grant committees should allocate financial resources for such studies in the future. After these beautiful 60 seconds, let me introduce myself. My name is Lili Rozgonyi. I'm a pediatric dentist at the Department of Pediatric Dentistry and Orthodontics. And my vision is that all children in special care are smiling, and to achieve that, I would like to evaluate the effectiveness of alternative dental management in case of these children. I have 3 specific goals and 3 ongoing projects. All of them started last year in autumn, and all aimed at investigating the dental care of children with special needs. Let me start with the first project, which is investigating the effect of alternative audiovisual techniques and dental environments for children with neurodevelopmental disorders. Neurodevelopmental disorders are increasing globally in the 21st century, affecting more than 53 million children under 5 years. These children are more vulnerable for oral health diseases, where 60% of children with autism have dental caries. Oftentimes they require general anesthesia for regular dental treatment, but this is not always necessary, so therefore there is an unmet need for some less invasive calming technique, leading us to investigate alternative dental environment and audiovisual techniques. Our clinical question is that what is the effect of the different audiovisual techniques and dental environments on dental management in children with NDDs? We used the PICO framework, and we hypothesized that the use of audiovisual techniques are superior to conventional dental practice. We conducted our systematic search on 5 databases with the search key shown, and with the help of my co-investigator, we were able to narrow down the number of eligible articles for quantitative synthesis to 20. Now let me show you some of my results. In the first figure, we can see the mean difference of subjectively measured cooperation levels in children with neurodevelopmental disorders during different dental treatments. Children with neurodevelopmental disorders have difficulties during dental treatments due to their behavior, so it is important to assess their cooperation. And for this, we can use certain scales. The most commonly used scale in dental practice is the Frankel scale. This is a 4-point scale from 1 to 4, from definitely negative to definitely positive behavior. Most of the studies used here the Frankel scale, and the one that used another scale were converted into Frankel scale. We analyzed 6 studies, 1 cross-sectional study and 5 crossover comparative study with 402 patients. The heterogeneity is moderate with a y-squared of 70%, which can be due to the different type of NDDs and different interventions used. The overall effect was a mean difference of 0.46 points on this Frankel scale, which is an 11.5% increase. In the next figure, you can see the mean difference of subjectively measured anxiety levels in children with NDDs during dental prophylaxis. As anxiety is one of the most common reasons of a failure of a dental treatment in case of these children, we can also assess the anxiety levels during the dental treatment. For this, we can use different scales, but in this case, the used scales were converted to Wenham scale, which is a 6-point scale from 0 to 5, from low to high anxiety level. We analyzed 5 studies with 128 patients. These were crossover comparative studies and RCTs. The overall mean difference was a minus 0.68 point on this Wenham scale, which is an 11.3% decrease. So as a conclusion, based on our results, we can say that audiovisual interventions improve cooperation and reduce anxiety in children with neurodevelopmental disorders. As an implication for practice, dentists and dental staff should have training how to use these techniques, and the interventions should be targeted based on the type of the entities, with focus on feasibility and accessibility. And as implication for research, we need larger, well-designed RCTs with stronger outcomes which are patient-centered and where we compare different interventions directly. Here you can see the progress of my manuscript. Currently it's under internal review, and our first targeted journal is the Journal of Dentistry. Let me move on my second project, which is investigating the effectiveness of visual oral health educational techniques for hearing impaired children. Hearing loss affects 34 million children worldwide. Due to communication barriers, these children develop higher risk of oral health problems. There is a significant difference between hearing impaired and non-hearing impaired children's toothbrushing knowledge. Maintaining good oral health is essential for physical health and well-being, because if a child has problem with its teeth, he or she can have difficulties in sleeping, eating, or concentrating, so we have to do something against it. Educating children has been a vital part of preventive dentistry to improve oral hygiene, so therefore there is an unmet need for some visual oral health education technique for hearing impaired children to teach them how to brush their teeth properly. Therefore, our aim is to identify the best oral health education technique for children with hearing impairment. Our clinical question is that are visual oral health education techniques effective in improving oral health in children with hearing impairments? We use the PICO framework, and we hypothesize that hearing impaired children receiving visual oral health education will have better oral health indices. And in practice, our aim is to make dental health lessons more accessible for hearing impaired children, leading to less invasive dental treatments in the future. And let me show you my third project, where we are analyzing data from the Eurostat database, and we are investigating the access to dental care services for people with disabilities in Europe. Approximately 1.3 billion people live with a significant disability today, which means that 1 in 6 of Earth's population are disabled in some kind of way. Individuals with disabilities should have equal access to quality healthcare services, including the professionals who are trained to address their specific needs. The oral health of these people may be neglected because of the focus on their disability, other major diseases, or the limited access to oral care. So therefore, our aim is to investigate the possibility of providing dental services to patients with significant disabilities. Our clinical question is that do people in Europe with a disability have lower chance to go to dentist compared to non-disabled one? We use the PICO framework, and we are interested in the unmet need for dental examination and for the reason of this unmet need. We hypothesize that people with disabilities have less frequent dental follow-up, and the clinical implication is to establish a system where patients with disabilities have easy access to dental health care. Here you can see a progress of my third project. We finished the research proposal, and we will send out the data request soon to the Eurostat. Here is a little summary of my 3 projects. I am planning to submit the first one soon in September, and the second and third one next year. Let me finish my presentation with the quote from Stephen Hawking: "The greatest enemy of knowledge is not ignorance, it is the illusion of knowledge." Thank you for your attention.
Thank you very much. Is there any question from the audience?
Thank you for your amazing presentation, Lili. For your first project on the first forest plot, I think you mentioned some audio-visual techniques with using the IVR and the non-IVR. So I was just curious if there's any other audio-visual techniques that are done. And also the other question is that, isn't it worse if they put an IVR on a kid while they're doing the procedure?
Thank you for your question. Yes, there are other type of audiovisual techniques which are not mentioned here, and unfortunately I don't have forest plot regarding these techniques. For example, video modeling, where they show a video to the kid of an adult or of other children who are undergoing the dental treatment, or the visual pedagogy, where they show pictures or other type of videos to the children. And regarding your second question, well, it depends on the child, but I think it can distract them from this environment which make them anxious. So I think we should give it a try.
Thank you.
Thank you.
Thank you for your presentation. Do you have any data about the effects of these interventions on healthy children?
Thank you for your question. Well, there were, I think, 3 articles where they also compared these children to typically developed or healthy children, and the effect of these techniques were bigger in case of the children with neurodevelopmental disorders and not that effective in healthy children. Thank you.
Thank you for your nice presentation. My question is related to your first project. Why general anesthesia cannot be an option for every children with NDDs for the dental treatment?
Thank you for your question. So, general anesthesia can be an option for everyone, but as it has, it can cause adverse events, and it also has a very high cost, and also it doesn't address the long-term behavior problems of these children. And also, for example, in Hungary, children must wait months to be treated under general anesthesia, even if they have pain. So that's why I think we should consider these interventions as an option before using the general anesthesia immediately.
Thank you.
Thank you.
Thank you very much for your nice presentation and your report. I may have a question. Maybe it sounds weird, but how did you define children regarding their age? How would you give a definition on children? How old are they, or what is the range that you examined?
Mm-hmm. So these children, and they are also adolescents in these studies. So they differ from 3 to 18 or 21 years old.
All right, and did you consider to assess these ranges in between? I mean, that you just involved in your study, or in the future maybe, or may it have any effect on your study? What do you think?
I think yes, it can have an effect, because the bigger the child, maybe they can be more cooperative or less anxious. But unfortunately, I didn't have the chance to differ the ages in this study.